Thank you everyone for the questions and clarifying things. You can keep on asking questions in the WhatsApp group, or you can just send an email or call us for any queries. So today we are starting with Introduction to Palliative Care as our first session. Today we have Dr. Divakaran as our faculty. He's graduated from Kozhikode Medical College and he's been practicing palliative care since its early times in Kerala. And he is the founder secretary of Pain and Palliative Care Society in Thrissur. And he's currently the director and faculty at Institute of Palliative Care at Thrissur. And he's involved in many training programs inside Kerala and other national training programs. He's a very, very experienced person in the field of palliative care. I'm so glad that he could find some time to be with us today for the introductory session. Welcome, Dr. Divakaran, for another session with the TIPSICO Palliative Care Program.
Thank you very much. Can I share my slide?
Yes, sir. We have enabled sharing from.
Am I audible?
Yes, sir. Very clear.
Okay. And you can see the slides.
Yes, sir. We can.
Okay. So how much time I have?
Sir, we have around 50 minutes for you.
Okay. Thank you. I'll try to finish it. Okay. I'm trying to address the issue under the following headings. The need. Why there's a need for palliative care, and the history of palliative care, and the philosophy behind, the care philosophy behind palliative care, how palliative care is defined, and models of palliative care delivery, and the concept of recognized medical institution. First of all, the need. Actually, we have to think, why did the mainstream medicine fail to address patient suffering? We know palliative care is for addressing the patient suffering. Why was it not addressed in the mainstream medicine? We had to form another subspecialty called palliative care. So this is a question. This is the answer is that mainstream medicine is disease focused. That's the main problem. Actually, the patient is having an illness experience. That is the experience of the suffering of the patient. It has got several dimensions: physical, psychosocial, spiritual, etc. And the whole thing is meant by the illness experience of the patient. And what about disease? Disease is a structural disorder of the organs and tissues that give rise to signs of ill health and assumed to be the cause of suffering. It's only an assumption. There's no, it's not validated. So the problem is that the symptoms are thought of as just manifestation of the disease and is best dealt with by treating the underlying disease. So this is our approach. Patient is having suffering and that is due to a disease, and we treat the disease and the suffering will be over. That's the reductionist approach we follow in the mainstream medicine. And what is the problem with this approach? The disease focused approach results in undertreatment of symptoms leading to underlived suffering. Undertreatment of suffering, undertreatment of symptoms, because symptoms are seen only as signposts, which point to a particular disease. So we give no much importance to symptoms, because symptoms are only signposts which point to a particular disease, and we are focusing on the disease. And another problem is the loss of physician's interest when the disease becomes incurable. And what happens? That we are focusing on the disease, and disease has become incurable. Then we have nothing to do more. So we ask the patient, okay, that's all we can do. you can go home. So we are abandoning the patient. And there is, of course, the impact of non-communicable disease on health status steadily increasing. And we know that by 2030, almost 50% of India's disease burden will be due to old age problems. It is interesting to know that what is the palliative care coverage in India. It is only 2 to 3%. 2 to 3% of, not 2 to 3% of population, 2 to 3% of those who need palliative care. Whereas in Kerala, it is almost 60 to 70% there is coverage. Yeah, there's a huge difference. And 67th World Health Assembly, one of the agenda was that strengthening palliative care as a comprehensive, as a component of the comprehensive care throughout the life course. It has said that to ensure palliative care is an integral component of all relevant global disease control and health system plans, including those relating to non-communicable disease and universal health coverage, as well as being included in country and regional cooperation plans. The thing is that the whole policy makers envisage palliative care has to be something to be incorporated into the mainstream medicine. It's not supposed to be a standalone specialty. It has to be incorporated into the mainstream medicine. And that's why the National Program in Palliative Care, NPPC 2012 of India government, has said, encourage attitudinal shifts among healthcare professionals by strengthening and incorporating principles of long-term care and palliative care into the educational curricula of medical, nursing, pharmacy, and social work courses. And in Kerala, we are fortunate to have the curriculum placed into the MBBS curriculum, palliative care into MBBS curriculum. So, and after that, in 2017, the Lancet Commission report said suffering is health related. The palliative care is something to be meant for addressing the serious health related suffering. Suffering is health related when it is associated with illness or injury of any kind. Suffering is serious when it cannot be relieved without medical intervention and when it compromises physical, social, and emotional functioning. So palliative care should be focused on relieving the serious health-related suffering that is associated with life-limiting or life-threatening conditions or the end of life. So we see a gradual change in the purpose of palliative care. Actually, in the beginning, it was meant for only cancer patients, incurable cancer patients. And then it was given for any long-term illness where there is suffering. And now, with the Lancet Commission report, we are understanding palliative care as something which addresses the serious health-related suffering. So here, the factor that qualifies a person for palliative care is not the longevity or not the type of illness or something, but it is a suffering. Not the longevity or the pathology or anything. It is the suffering that qualifies a person for palliative care. And the history, I think I should not dwell much about. As a compassionate care, palliative care has a long history dating back to 1879 when the Mother Mary Aiken had formed the Irish Sisters of Charity, and she actually, it is supposed to be Mother Mary Aiken had who coined the term hospice care as end of life care. Before that, hospices were meant to be shelters for pilgrims, and she started the hospice in her own home in Dublin for caring the destitutes, and because for her, death is not the end of the journey. The journey has to continue. So she she adopted the term hospice into the end of life care scenario. But a meaningful palliative end of life care or palliative care was introduced by Dame Cicely Saunders in 1967. Her that is the first modern hospice. You can forget about Mother Mary Aikenhead and all, but you should not forget Cicely Saunders. She is a remarkable lady who started her career as a nurse, then became a social worker, and she learned medicine and became a doctor. And the Queen gave her the status of Dame Cicely Saunders. And she's the first founder of the first modern hospice, St. Christopher's Hospice in London. And the term, actually, that was a hospice. The term palliative care was coined by Dr. Belfort Mount in 1974, who was a urologist and a oncosurgeon. He must be a poet to introduce such a beautiful term. Pallium is a Latin word. Pallium means to cloak, to cover. So when you can't cure the disease, you cover and protect the patient with the blanket of effective symptom control through comprehensive care. That's the meaning of palliative care. So ultimately, it is improving the quality of life. And regarding the philosophy, I think Dame Cicely Saunders has given us the philosophy of care in palliative care. You know that we were in the mainstream medicine, we were focusing on the disease and we were seeing patients as only carriers of disease. But actually, these patients are whole persons, and we lose sight of the person. So Cecily Saunders said that we have to see the person behind the disease. So how are we supposed to see the patient, or what message we are going to give the patients, how we see them? That's something not to be verbalized. It has to come out of your actions, your gestures, your body language, your facial expression, etc. But when you put into words, it's something like this: you matter because you are you. You matter to the last moment of your life. And we will do all that we can, not only to help you die peacefully, but to live until you die. This is it. You matter because you are you. You are not telling this to a celebrity or so. You are telling this to a patient who might have lost the human form itself. His face might have turned into a rotten cauliflower, but he's important because he's a unique person. There's nothing to replace him. So we are recognizing the uniqueness of each individual, each patient. So this is the message we are giving to them. You matter because you are you. And this importance lasts until the last moment of their life, because they are unique individuals, irreplaceable, invaluable. So this message we are giving. And we are not going to stop any treatment, or we are not we don't even the thing is that even the life limitation of the life expectancy doesn't reduce the importance of their life. That's it. And we will do all that we can, not only to help you die peacefully, but to live until you die. So our concern, the concern of palliative care is not about death. It is about the life and how we are going to make the life livable. That is the question. And there is the concept of total pain. This is also from Cecily Saunders, because all the suffering put together, that's what the patient experiences. A person is having a physical pain. There is a physical, so many physical issues, not only pain, but a lot of suffering. And along with that, there will be psychological issues, social issues, and spiritual issues. And all these things interact with each other. And what the patient is experiencing is a total pain. And people often feel that palliative care is something related to charity work. There's nothing charitable in palliative care, actually, because it's only a human right issue. As the Human Rights Watch said, to leave a person in avoidable pain and suffering should be regarded as a serious breach of fundamental human rights. So, by virtue of being a human being, I have a responsibility to see that my fellow being is not not suffering. I have a responsibility to alleviate the suffering of my fellow being. So we are doing only this human rights uh, issue. And this is something very interesting because there's a book written by Sheila Cassidy, Sharing the Darkness, her experience with working with dying patients. And there she says, slowly I learn about the importance of powerlessness. I experience it in my own life and live with it in my work. The secret is not to be afraid of it, not to run away. The dying knows that we are not God. All they ask is that we do not desert them. Because these patients know that we are not God. But only thing they ask is that you do not desert them. And she has picturized in a cartoon she herself made. The first thing, I think most of you might have seen it in Robert Toycross introducing palliative care text. He has reproduced it there. In the first slide, we see the doctor with all his power and glory, and the nurse standing as an aide very close by, and the patient. And the other one is a clergy who also has all the uniform and all everything. And gradually, all these things become irrelevant. And ultimately, lastly, we become a nude to human figures. We are empty hand. What is the gadget by which a palliative care physician is going to treat a patient? It's not the BP apparatus or stethoscope or magnetic resonance imaging. It is his self. We have to say that. So, and this is an interesting article by Michael Carney, a palliative care physician in Palliative Medicine Journal, because you know that in 1967, the first modern hospice started in 1967. But we had to wait till 1987 when the Royal College of Physicians in London recognized palliative medicine as a subspecialty of general internal medicine. So these 20 years, several palliative care physicians were working tirelessly, alleviating the suffering of a lot of patients, and a lot of GPs were benefited by the work of palliative care physicians, but there was no recognition. In 1987, there was recognized as a subspecialty of general internal medicine. And naturally, there was a lot of jubilation and everybody very happy. And at that time, a dissenting note was made by this Michael Carney. He said, I'm afraid we may be in the process of selling our soul to the very medical model whose successes have created the needs our specialty sets out to meet. So we know that there is a dehumanizing aspect in the mainstream medicine because reducing the patients into organs and tissues and disease processes. And we are fighting against it, and we are rediscovering the human being behind it. So by joining the ranks of the specialists, are we selling our soul to the medical model? And another thing, very relevant thing he asked, is that the potential for physicians working in palliative medicine to go beyond symptom control to create conditions where healing at a deep personal level may occur for the individual patient. That's very important. That is, he asked a very pertinent question. Why should we alleviate pain? Why should we alleviate pain? Is that because pain is unpleasant? It's not only that, because behind every pain, behind every suffering, there is a possibility, a potential for growth of the person as a person, as a human being. So, but the patient in pain will not recognize it, cannot realize it, because he's all engrossed in pain. When once you alleviate the pain, then only the patient reflects, what was the experience I went through? What was the meaning of it? And this introspection, through this introspection only, he can achieve that growth. So a palliative physician is not only a symptomatologist. He should have the potential for creating healing at a deep personal level. Okay. Now we come to the definition. WHO definition in 1990. It was palliative care is active total care of patients and their family at a time when the disease is no more responsive to curative treatment. That was the original idea about palliative care, because when all the curative prospects are failed, we move to the second compartment of palliative care. And this is injustice, because he is having all the physical, social, psychological, spiritual, and all the suffering from the day one of the disease diagnosis itself. You know that when the diagnosis of cancer is made, one patient said, when the diagnosis of cancer was made, I was on one side of the wall and the rest of the world on the other side of the wall, the normal side. So it's an isolating experience. So a lot of suffering, these medicines, the treatment, investigation, everything is painful, spending a lot of money to reprioritize everything in the family. So he is undergoing through a lot of suffering. And we are focusing on the disease. And our agenda is whether it is an adenocarcinoma, whether it is squamous cell carcinoma, whether surgery is the one, or radiation is the one to be done, or surgery, or a course of radiation and then surgery. And all this, throughout this time, the patient is suffering. And we are not, we know that he is suffering, but we think that it is due to disease. And when once the disease is cured, he will be all right. So he, after all, he is suffering a lot of suffering, and the only at the end of the life he gets palliative care. So we have changed that the definition into palliative care is an approach that improves the quality of life of patients and their relatives facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. The definition became pretty long, but it includes that we have to identify the problems, the cause of suffering early enough, and we have to meticulously assess and treat aggressively the problems, and so we are not supposed to wait till the end of life, or all curative aspects are lost. And this early palliative care has beneficial effect. We have no scientific evidence, because there was an article in New England Journal of Medicine. They divided the non-small cell lung cancer patients into two groups. One, they gave only conventional oncology treatment only, and the other half they gave palliative care simultaneously. And after a period when the groups were compared, the group which received palliative care also had a longer survival. They had a longevity more than 3 months than the other group, and they had a better quality of life, and they had improved mood. The depression rate was very much less in the group which received palliative care from early in the course of the treatment. So now nobody thinks that palliative care is something to be given in the end of life, or when all curative prospects are lost. It has to be given whenever there is suffering. We have to start palliative care. So palliative, in short, palliative care is an active total care, provides relief from pain and other symptoms, affirms life, and regards dying as a normal process. This is something important. Okay, we know that the sanctity of life and all, and we respect it. At the same time, we know that dying is a normal process. Because this we have to reiterate, because as medical persons, we feel that all deaths are therapeutic failures. So, all deaths are not therapeutic failures. There are therapeutic failures. At the same time, there are normal death also. And so palliative care intends neither to hasten nor postpone death. Palliative care neither hasten death, because that belongs to the category of euthanasia. and we are not believing in euthanasia in palliative care. And we are not postponing dying process also. Prolonging life is a good thing, but in this process, if we are prolonging the dying process, that's meaningless. So palliative care doesn't neither hasten nor postpone death. It integrates the psychological and spiritual aspects of patient care and offers a support system to help patients and their family. Sorry.
Sorry, sir. I think someone unmuted by mistake. Please continue, sir.
Okay. It uses a team approach, will enhance quality of life. It's applicable early in the course of illness, as we said, with other therapies that are intended to prolong life, and includes those investigations needed to better understand and manage distressing clinical complications. Palliative care means it's not treatment. It is active treatment. So this is the usual scenario we are familiar with. The acutely ill patient in the hospital usually get cured, back to normal, except perhaps for the added financial burden, goes home, resume routine activities. This is the usual scenario. And what happens to the patient for chronically ill and incurably ill patients? What happens to the patient who needs regular attention for the rest of his or her life? They are not going back to the normal life. They need continuous support. What happens to the patient with incurable cancer after getting discharged? A patient with oricutaneous fistula and and we have put a rice tube to feed, and he has gone home. He has no further curative treatment, but he has a lot of suffering. Or the man who fell from the coconut tree and became paraplegic. When these patients are brought to our casualty, we rise to the occasion and do everything possible to alleviate the pain, etc., etc. And when once the spinal injury is confirmed and he became paraplegic, there's nothing more to be done, and he is sent back to home with a continuous urine drainage, and so he's having multiple losses. He has lost his job. He has lost his wife because the wife have become a home nurse, the role of home nurse. And what about the sexual life? There's a lot of issues, but we think that we have done everything possible. But actually, we had to do a lot of things further to alleviate the suffering of the patient. Or patient with a major CVA. When these patients are CVA patients are brought to our clinic, we do everything. But when we send them back with a rice tube in situ, then what happens to them? We have to think about that. Here comes the importance of role of community, because many of the problems in advanced disease are of a non-medical nature. The community has a major role to play in addressing the problems. 75 to 80% of the problems are has to be settled through the community intervention. Only 15 to 20% of the issues are addressed by doctors and nurses. So there is a huge role for the community. So we have to, if a unit worth the name of a palliative care unit should have a community backup. Then, because access to care is the key for the chronically ill, chronically terminally ill, prone for crisis, service should be available 24 hours a day, 7 days a week. Because these patients will have urine retention, we have to introduce a Foley's catheter, and then within another couple of days, it may get blocked, and we have to relieve that block, or it may start leaking. We have to change the catheter, and by the time he may feel difficulty in swallowing, you have to introduce a rice tube, and we have to be wary about the bed sore and all. So whenever all these things, these issues crop up every day. So whenever these issues come, they have to travel all the way to nearby city and show them to the hospital. That's not the way it should be done. It's important that good quality service are available close to home as possible, as close to home as possible. And this will be possible only if help is available in the local community. So palliative care should be available in the local community. And for that, we need home-based care. Home-based care is the backbone of palliative care. It is possible to manage patients with advanced disease at home. And people prefer to spend their last days at their own home. And home-based care is cost-effective. And complications are less in home-based care with empowered partnership of the community. So this is a slide I prepared in light vein. Don't take it seriously. Just just compare and contrast the mainstream medicine. We know that there is no hard fast compartmentalization between mainstream medicine and palliative care, and palliative care has to be incorporated into mainstream medicine. So just for a relaxation, we can just compare. In the mainstream medicine, the ethos is military virtue of fighting, not giving up. Endurance, hardness, and physicianism. The disease is a foreign invasion, and we have to fight against it. That's the spirit. It's a military virtue of fighting in the mainstream medicine. Whereas when you come to the palliative care, the white flag has already been flown. So here, but we are worried about one thing, that is the human dignity. In whatever way the patient is incapacitated, we have to preserve the dignity, human dignity of the patient. And so patient is sovereign and he is the central position. And in mainstream medicine, there is a hierarchy. The doctor on the top, then the staff nurses, then the attenders and everything. Whereas when we come to palliative care, there is not that hierarchy. The patient is in the center and everybody is around him, putting their own effort to make the patient comfortable. So patient is sovereign there. And in mainstream medicine, the physician is all powerful. He has the knowledge of several Greek texts, and he has an array of medical therapeutics, and there's a battery of investigations. So he's feeling powerful. So whereas in palliative medicine, the physician knows the powerlessness, and this knowledge is the power of physician, palliative care physician. And in mainstream medicine, it is curing, whereas in palliative medicine, it is healing. And there is difference between curing and healing. I'm sure you know that. And in mainstream medicine, diseases are always seen as a problem to be solved. Whereas in palliative medicine, it's an experience to be lived. And how are we going to make the experience livable? And when imminent death happens in mainstream medicine, the urge is, don't stand back, just do something. One man fell upon his chest and start compression, and another person runs for endotracheal intubation, another one withdraws adrenaline, another one tries an IV access, etc. But so that's it. Don't stand back, just do something. Whereas when that such a situation happens in our palliative medicine, don't just do something. You stand back. An important thing: long-awaited demise of the patient is happening. Don't tamper it. That's it. And death as failure of treatment. As I said previously, always we think death as a therapeutic failure, whereas in palliative medicine, death is an inevitable reality. We see it as an inevitable reality. So palliative care needs a new way of seeing combined with a new way of acting. We are seeing these patients, we have seen a lot of diseases, we are seeing a lot of patients, but we are starting to see a new way of seeing these patients, and we are combining it with a new way of acting. So this is the comparison of the mainstream, the acute care and chronic care. In the acute, the left one, the health status of the patient suddenly drops and he recovers. Whereas in the second one, it is the health status gradually and definitely deteriorates, and ultimately he dies. So The chronic disease with steady decline of health and acute crisis in between is very different from acute disease with a brief period of illness, because the needs of these two patients are very different. We have the skill to address the issues of the acute patients, but we have yet to develop the skill to treat the needs, to meet the needs of the patient with chronic illness. Now, models of palliative care delivery. And we know that palliative care in India started in 1984 with the introduction of Gandhi Shanti Avedan Ashram in Mumbai, 1984. And within another couple of years, its branches opened in Delhi and Goa. But such hospices are expensive and it's not in line with the cultural ethos of our close-knit family setup. So, palliative care unit, which is economically feasible and adapted to the culture of our nation, was started. The first was started in Calicut in 1993 or 94. So that became a very sensational news in palliative circle world over. And a resource poor country like India has started a palliative care unit. So a lot of research were done behind the success of this model, and it has been identified as one is the utilizing the existing infrastructure facility in a government hospital. They did not try to purchase land and raise building. They just cleaned up a room which was not used in the medical college hospital and started seeing the patients. And when once they started seeing patients, then they understood the doctors. And you know that it was started by Dr. M.R. Rajagopal. He was the professor and HOD of anesthesia department in Calicut Medical College. And he, with his student, Dr. Suresh Kumar, and one of their common friend, Mr. Ashok Kumar, they started the initial palliative care unit there. And then they understood that doctors are not enough to manage a unit, and they need nursing staff, etc. So they are not getting nursing staff for that, and their friends and friends' wives, spouses, they start chip in and do whatever they can do, and that filling the gaps with volunteers in the community. That was the second success factor. And they knew that if they can teach the family members about the care at home, how to prepare sterile dressings, how to sterilize this dressing with the limited resources in their own home, they can do a lot of things. So empower the family and make partnership with the patient and family. That is the factors which made the Calicut model a success. And then came the neighborhood network in palliative care. When Calicut Pain and Palliative Care Society started their link centers in other peripheries like Malappuram districts, there's a lot of social capital there, and volunteers started to lead the process. They had a lead role, and they started identifying patients who need palliative care, and that changed the whole color and texture of palliative care till then. Because when we doctors, professionals, identify patients with palliative care, we have our own professional bias. Oh, this patient is having lung cancer and he needs palliative care. Oh, this patient is having COPD. He needs only occasional dietary induction, etc. That's our attitude. Whereas when common people, volunteers, when they started seeing patients, they identified patients not on the basis of the diagnosis, but on the basis of suffering. And they understood that there is no much difference in the suffering of the COPD patient and lung cancer patient. So they included COPD patients, end-stage cardiovascular disease patients, chronic kidney disease patients, chronic liver disease patients, psychiatric complaints. So the area of palliative care expanded. And another thing is that when the common people, the volunteers, took the lead role, they took the ownership of the project. And when this ownership falls into the hands of common man, it gets more sustainability because their felt needs, they're addressing their felt needs. So they will find out means for sustaining it. And so essentially, NNPC, Neighborhood Network in Palliative Care, is an empowerment of the local community to look after the bedridden patients in their area and to develop a cost-effective method for the provision of palliative care in our settings. It consists of a network of trained volunteers in the community and a support system by trained professionals, institutions, and organizations, which back up the volunteers in the community. That is called Neighborhood Network in Palliative Care. So, Journal of Public Health Policy has appreciated the work of Neighborhood Network in Palliative Care, and they said this community approach in palliative care, 28 years after Alma Ata, shows the way forward for palliative care to palliative care for all. If similar strategies can be employed elsewhere, that would be a very important step forward for global palliative care. So, actually, this community approach in palliative care has expanded the palliative care coverage in Kerala. And you might be remembering the Economist Intelligence Report of 2015 or so, the quality of death index in several countries, and India was placed in the 67th position or so. And in that article, they have said that there is a small state in the southernmost part of India, which is a beacon of hope. And they are talking about Kerala. And the reason is that the coverage, palliative coverage in Kerala, which has improved the quality of death. Now, we came to palliative care policy that was introduced in 2008. And the Kerala people can really boast about this thing because Kerala was the first state to announce, to declare palliative care policy. And that was introduced in 2008. And they have thoughtfully formulated the policy as a combined effort by community-based organizations, local self-government agencies, and local government healthcare institutions. So we have preserved the voluntarism and compassion element in the palliative care. It is not a mere government program. It has the vitality of community-based organizations, and at the same time, the robust infrastructure facility of a government setup. And this is the public health approach to palliative care, because the care in the community by volunteers is the base. And there the prevention, early detection, and management, and addressing the psychosocial issues, everything happens in the care in the community by volunteers. And in the primary healthcare, there is the secondary palliative care. There they will get the medicines needed to address the medical and the clinical and nursing issues can be addressed in the primary health care. That is the secondary palliative care. And tertiary palliative care or specialist palliative care is available only in district headquarters, medical colleges, etc. This is the public health scenario in Kerala of palliative care. In recognized medical institution, that was an attempt to make opioids available to the need, because in the after the 1985 Narcotic and Psychotropic Substance Act, which was a draconian act, the usage of opioid fell by 80%, because that was such a draconian law. that nobody wants to prescribe or want to purchase, store, or dispense morphine. And then Supreme Court intervened and said to amend the narcotic and substance narcotic rules so that needy patients get morphine. And as usual, Kerala was the first state to modify the Narcotic and Psychotropic Substance Act. And according to the new rule, a drugs controller of a state, if the drugs controller of state identify a particular unit as a recognized medical institution, they can directly purchase, store, and dispense oral morphine. That is the amended rule. And for the drug controller to recognize a particular unit as a recognized medical institution, there are certain criteria. And the major one is that a doctor with minimum 10 days hands-on training in palliative care from a recognized training center should be in charge of that unit. He's supposed to manage the unit. A doctor with minimum 10 days hands-on training in palliative care from a recognized training center. And a double locking facility for storage of oral morphine tablets, and a basic infrastructure facility for the care of the patients. So if these things are satisfied, the drug controller will issue a certificate named recognized medical institution. And when once that certificate is obtained, they can purchase, store, and dispense oral morphine. I think I have covered all the things I wanted to talk to you. And if there is anything, any area which needs explanation, of course, we can discuss. Thank you.
Thank you so much, sir. So to the participants, we would like to hear from you, either questions from your side, or if you want to share some ideas or your experience, please feel free to share. You can either type it in the chat, we can read it out and discuss, or unmute and talk. Is there anyone in this group who's like involved in already existing palliative care services? Yes, Dr. Shaleen. There are two. Yeah, Dr. Priyanka and Dr. Smita. Dr. Priyanka, is it a question, or you are just you are already involved in palliative care services? Dr. Priyanka, can you just unmute yourself and?
How to unmute?
Oh yeah.
Okay. Right. So can I respond?
Sorry. Yes, yes, Dr. Shaleen. Yes.
Right. So yes, I mean, you know, we are in a radiotherapy facility, and palliative care is a part of our daily care. I mean, our prescription is both oncology, pain management, breathlessness management, anxiety, ulcers, the usual story. It's there all the time. We have a facility, there is also morphine here, and we are both anesthesia as well as radiotherapy in this specialty in SGPGI Lucknow. So we do it all the time and in all manner, including patients with terminal disease. And also, oftentimes we find that patients with terminal cancer don't die of the cancer itself, but die of other problems where they need support. For instance, aspiration is a very common problem that happens in patients who are obtunded, and general debility. And so maintenance of nutrition and keeping good cheer, and of course, dealing with the family also, and avoiding needless investigations. And, you know, and that is our main goal. That's what we do day in and day out.
Thank you. Thank you so much for sharing, Dr. Shaleen, about your setting and the activities that you are already involved in. Thank you so much. Dr. Smita, yes, I've seen your question. Like, who decides when the patient moves to palliation? Dr. Divakaran, would you like to take up that question?
This is Actually, we know that palliative care is not a strict compartment. Palliative care has to be integrated into the mainstream medicine. So whenever there is suffering, we had to introduce palliative care into the care of the patient. So there is no interface, curative, palliative, there is no interface there. So we had to go hand in hand, the palliative care. So you need not wait until the patient is terminal, or there's no fixed signpost which say, okay, now palliative care. No, palliative care has to be there from the day one of the diagnosis of a incurable illness.
Thank you, Dr. Divakar. Yeah.
Dr. Smita, is that clear, or you have?
Yeah, I got it. Yeah, maybe I was talking about the palliative care. I understand what Dr. Divakar mentioned, that it is a continuum. It has to be there as part of clinical care from day one. Only thing is, maybe my question was not clear. I mean, I should have worded it differently. When you move a patient into an end of life care and decide that there is no other what should I say, active the therapeutic thing from a clinician point of view, though there is symptom management, who decide, like, nothing more can be done? Should it be a policy where there be 2-3 people together who make that decision? Yeah. Physicians.
Okay. There is no point where nothing more can be done. There is always something we can do. So it's only that what is the appropriate treatment for that patient? Is it a treatment in the curative intent, or is it in the palliative intent? I think that's the best person to decide is the oncologist itself, because he knows that there are a lot of protocols, and there are a lot of scoring systems whereby the palliative performance scale. Through that, we can understand that the patient will not benefit with curative treatment with curative intent. He needs palliative care. I think that has to be decided by the oncologist.
Thank you, sir. Thank you, sir. I would like to add one more point. Dr. Smita, I think it's all about starting as a team together. There is nothing like, as Dr. Divakaran was mentioning, it's a continuum of care. There is nothing like, now it is exhausted. Now we have to decide and send only for supportive care. I think the supportive care team should be involved from the beginning, so that the patient doesn't feel the quick transition from the curative to palliative segment. It's the same team who is seeing the patient till from the beginning of the suffering towards the end. So I think it's a smooth transition, or a continuum of care which starts from the beginning of identification of suffering. Yes, maybe the goal of care changes from curative to supportive, but the team should ideally be the same from the beginning towards the end. Just sharing my point of view. So there is another question from, sorry. There is another question from Dr. Benny. Is there a role for hospice centers in India? Like the hospice with the NHS in the UK? Do you think is there a role for hospice centers in India?
I don't know actually, but sometimes the ideal thing is that the patient should be managed in their own home. That's the ideal thing, but that's only an ideal. But sometimes they may be institutionalized. So there is, of course, there is a place for, there's a role for hospice care in India also.
Yeah, but it becomes quite financially burdening most of the time, the hospice care institutes. And for most people, I think it's pretty financially devastating. So even if it works, it wouldn't be accessible for most of the people who would actually need it, I think. I mean, that's what I think, and what I've experienced from. So like Dr. Divakaran said, the community-based model with people being at home and having access to this at home would any day be better, of course, but I mean, that's what I think.
Yes, Dr. Manjari, I totally agree to that, because in a country like India, where the resources are already limited, the more it is integrated into the community and into home-based care, the access is much better, because I think the extent of suffering is much more when compared to any other country in the world. Thank you so much for sharing your insight about it. Dr. Manjari has asked a question on how to begin working on community involvement to initiate a community care model in a small town. We have one specific session on involving the community, but I would like to hear from Dr. Divakaran from his experience that how to involve community model in a small town.
Actually, we start by introducing awareness programs in periphery. We'll identify some organization like Lions or Rotary or some XYZ organization in a local community and interact with them and form a start a awareness program. And once the awareness program is over, some people will start asking how to get training in this aspect, and then we identify people who are willing to serve as volunteers, and we give them structured training, 2 days theory session and 1 day with home care and 1 day with clinics and IPOP experience. So these 2 days theory session is done on 2 consecutive Sundays. The first Sunday we we introduce palliative care and we give a session on communication, and we give them a printed format to identify patients who need palliative care from their local area, and they are supposed to see a patient in their local community and fill the pro forma and come back on the next Sunday with that fill the pro forma, and we discuss about that particular patient, what are things we can do as a community volunteers, and how to access this medical and nursing facility, and thereby we interact with them, and once they form a network of their own, and they will identify the psychosocial issues of the patients, and we give backup support, the medical and clinical and nursing support from our unit, and thereby through this constant interaction, the concept of palliative care spreads in that local community, and support comes from the local community, start coming from the local community. That's the modus operandi we follow.
Thank you, sir.
Thank you so much, sir. Dr. Neelam, you are raising your hands. Please.
Well, actually, that was in response to the question that who okay. Working in a palliative care facilities. That was
Sir, there is a question on, I think that will be covered under ethics, where the patient wants palliative, but the family wants the mainstream curative trials, sometimes even the experimental therapies. Who would take preference if there is a conflict of interest?
Theoretically, we have to stand with the patient. But in a country like India, where there is a lot of power with the relatives of the patient, we have to get their consent also. I think a lot of communication needed, communication skill is needed. We have to discuss with the relatives and arrive at a decision, and convince them about the futility of such treatment. I think we will be discussing it in
yes, we have a session.
Communication.
Yes, we have a session on medical ethics also, where we'll be discussing these points. Dr. Haraprasad has asked, in a multidisciplinary specialty where there is like MD palliative medicine, anesthesia, oncology, handling the same patient who takes the final call as a consultant?
I think the patient will be under one particular specialty care, and he will be in charge of the patient, and the others will be consultants only. I think that's the usual way.
Dr. Hariprasad, do you want to ask more questions same line or?
No, it's fine. Yeah.
Sir, do you have any idea of current status of health insurance coverage for palliative medicine?
Sorry, I don't have any idea. Because we are running a palliative care unit where everything is given free of charge. So we are not bothered about insurance of our patients.
Dr. Hariprasad, I think up to my knowledge, we've proposed for including that in the Ayushman Bharat, under which some of the palliative elements are covered, but there is some ambiguity in terms of, because majority of the services are delivered at home. So it's not really clear, but yes, there are provisions to, I'll get you the details if I can, if possible, I'll share through email. If I can get access to some of the documents, I'll share through the emails. Any other questions? Any other hands I have missed? Someone? Yeah.
Dr. Divakaran, I just wanted to ask a question. I'm Dr. Pinky. I work for a cancer hospital, sir, as an administrator in a cancer hospital. I just wanted to know, sir, do you work for a hospice or you have a center attached to a center?
No, we have a standalone palliative care unit, which has a OPIP, home care, and a training center, and a physiotherapy unit. And we presently have started a hospice center also.
Okay, so where is it located, sir?
Thrissur town itself.
Okay, okay. Sir. One of our consultants, sir, he's a head and neck surgeon in oncology. He has a hospice, 10, 12 bedded hospice in a town called Rishikesh. So that's it, only a hospice, sir, nothing else.
Yes, Dr. Pinky, you work in, can you just like tell us where do you work?
So I'm working with Rajiv Gandhi Cancer Institute and Research Center, Delhi, Rohini, Delhi.
Thank you.
So we have a home care team, but we do not have as of now a palliative department or a palliative ward or anything. The only thing we have to support such patients is the home care team.
Yes, ma'am. Do you intend to start a palliative care service in your center?
We may. There is a request off and on which comes from the consultant. So that's why I thought that I'll also get in touch with this course and try to see how we can initiate.
Thank you. Ma'am, we have a specific session on organizing palliative care services, and we have a team called the facilitation team. They will be involved with any participants who would like to start their own services in their center. They'll get in touch and they'll be helping with all the processes, paperwork, organizing the volunteers. So they'll be involved in, they'll be in touch with you if you are interested to start till you start some services on your own.
So thanks. I think this, madam, this is a very useful information. And whenever I feel the need, I may get in touch with the team as well as your organization.
Sure. Thank you. Dr. Anish, please.
Yeah, so myself, Dr. Anish, I'm working in men's medicine, Trivandrum, as an intensivist and anesthesiologist. So the thing is that here in our ICU setup, we face a most common problem is critical patients coming in, and mostly they'll be integrated from the emergency department. And our main issue is counseling the bystanders regarding the condition and regarding palliation. So that is a main issue for people understanding. Understandings are on different levels. Some people don't understand that their relative is at the end of his life. So we have to make them understand the situation, and that is the most difficult part we are facing. So I intend to get a training in that part, the counseling part, the ethical part of that. And even I am interested in starting a palliative care center on my own, if possible, if it is feasible, but in future. Basically, I'm an anesthetist, so I think, and the intensivist. So most of the time I deal with palliative care emergencies. So I need more training in that section. So I have opted for case facilitation in palliative care emergencies also. And whatever sir said is a very valid point. Most of the patients and families are physically, emotionally, as well as financially burdened. So we, as sir said, I think home care is most appropriate. But a hospice like center, if it comes under some insurance coverage, it will be better. No? Is there any possibility like any private insurance which gives hospice kind of care, which covers a hospice kind of care? Is there?
I think one by one, regarding the prognostication and communicating the bad prognosis, we should have a very good training in communication. There is a session on breaking bad news in communication classes. So we had to learn that, the process of telling bad news to the patient, truth telling. And regarding the insurance issue, already been dealt with, because Ayushman Bharat, I think it is covered under this.
Dr. Anish, whatever you have been discussing about the emergencies and the communication, I hope we'll be able to cover in this 20 sessions course. And yeah, tomorrow we are having a session on specifically on ICU, the ethics of withdrawing, withholding life support. If you are interested, just let us know. We can send an invite for you to join, or anyone in this group who is interested, who's working in an ICU setting where we deal with withdrawing, withholding life support. We are having a wonderful discussion happening tomorrow at 6:30 online. So just send us a message. We can send you the invites. It's meant for pulmonologists basically and the intensivists. But yeah, we can, if you are interested.
Is it going to address the issue of DNI and DNR also, madam?
Yes, yes. The legal aspects of ICU and end of life. So just put the message in the WhatsApp group. We'll send you the invite. Whoever is interested can join. It's another course for pulmonologists, but I think as the discussion has come up, I think it will be beneficial for you all, people who are working in the intensive care. I think we can move on to, sorry, there is one more question from Dr. Mani. If a patient comes to us in advanced or end-stage cancer, we know the prognosis was bad. Bad if there is a benefit in continuation of treatment, or is it waste of money? I did not quite understand the question. Dr. Mani, would you like to just tell us what do you want to? I did not understand the question.
Actually, if the patient is coming at the end stage, because they will roam all around the hospitals, and they didn't take, and everybody will explain the guarded and poor prognosis. And if you take care or give the proper care, also is it benefit for the patient or it's a wastage of money?
Sir?
I think it's a communication issue. We have to sensitively communicate the patient about the bad prognosis and the futility of further curative, the treatment with curative intent. We had to have very good communication skill for that.
Thank you, sir. So as mentioned in the beginning, every session will have a lecture from the expert and followed by a case presentation from one of the participants. So today we'll be presenting from our side as an introductory part of it. So we'll have a case presentation for another 5 minutes, and then we'll have a discussion based on this presentation, where we would like to hear from you what do you think about managing this particular scenario. Next. So this is a story of 39-year-old male who came to us with traumatic quadriparesis with stage 4 pressure sores on the sacral region and the left gluteal region. So when he came, he was constipated for 2 days. There were bed sores over the sacral and the gluteal region, and he complained of complaints of moderate pain over the hip region. And he was having leakage of urine continuously for last few weeks. So in 2015, he had a fall while carrying a weight, where there was a neck pain followed by weakness of both limbs, and he was diagnosed with traumatic quadriparesis in August 2015. He was admitted and got treated from a government hospital, and he got discharged after that. So after 6 months, so you can imagine he got treated, but he is still in the bedridden stage and he is at home. So after 6 months, he developed a bed sore over the sacral and gluteal region, which when he came to us, it was stage 4. Coming to the pain history, he has a history of pain over the hip and wound site for more than 2 weeks. And pain over the hip region was 5 by 10 on a numerical rating scale, which he told it is an intermittent burning type pain bilaterally. And wound, especially over the wound, he had continuous throbbing type of pain, which he scored as 4 by 10 in numerical rating scale. Due to this, sometimes because of the burning sensation and throbbing pain, he keeps the wound open. And he told us that he has a disturbed sleeping pattern and reduced oral intake. On examination, conscious and oriented, normal temperature, pulse, respiration, BP, and other systems were within normal limits. So on examination of the pressure sores, we could feel warmth and tenderness over the pressure sore. There were exudates present. It was a foul-smelling wound with tunneling under the borders, and the wound was irregular in shape. So we did routine investigations, and I'm not reading it out one by one, but yeah, HB was 10 and creatinine was 0.9. Other parameters seem to be okay. And coming to the story of this patient, he was a 39-year-old unmarried man living with his mother, who is 65 years old, in a rented house. He has one sibling, and the sibling is married and living separately and cannot take care of or don't take care of them or help them. This patient was a manual laborer and he was the breadwinner of the family. Now the mother had to start going for work because she has to take care of this bedridden son. So she started doing manual labor work so that she can take care of him properly. And the main source of income, the main breadwinner in the family, is the 65-year-old mother, and they have to pay the rent and other expenses at home. And she has old age pension, and some of his friends help every now and then, but not too much. They have taken a loan from a private finance bank of around 1.5 lakhs. And he's a Christian, and he told that I'm unable to go to church, and which makes me really sad because he's now unable to move on his own. He has a cell phone and he communicates with his friends and relatives through the cell phone. And he says to his mother that I don't think I can walk. So please don't spend money over my treatment. You're already taking care of me at the age of 39. So just don't spend money for my treatment anymore. So the main concerns for him and his mother was pressure sores and the pain over the hip region and over the pressure sore, and these financial problems where he is unable to contribute anything to his family, and the mother has to work, and with a debt of 1.5 lakhs. So summary is that 39-year-old man with traumatic quadriparesis with bed sores present over sacral and left gluteal region, stage 4 bed sores with pain over the hip region. So these are the points that I would like to discuss today. Now we have heard from Dr. Divakaran about the basics of palliative care, what exactly palliative care covers, what do you mean by the whole philosophy of palliative care or serious health-related suffering. Do we need to provide palliative care for this patient? And what do you think will be the problems that he might be going through? And how can we help this patient and the family? As you know, in the definition, it is said that it is for the patient, not just for the patient, but for the family also. So how do you think we can help this patient and his mother? So I'll wait for 2 minutes for the responses from your side, either in the chat or you can unmute yourself and tell us. First question we'll take first. Do you think he needs palliative care? Does he come under the spectrum of palliative care? He's a traumatic quadriparesis patient who has undergone definitive treatment and come back home. Yeah. Yes, Dr. Priyanka. Yeah, I can see so many responses. Yes. So there is no doubt that this patient needs palliative care. Yeah, definitely yes. So that's one thing that I think we all can take home today, take home point for today's session, that it is not just for cancer or it is not just for patients who are dying, but it is also for patients like this patient right now we are discussing. Thank you for the responses. And can anyone tell us what are the problems, possible problems that he might be under? Yes, Dr. Arnab, please.
Yeah, so I think Sir has beautifully described the total pain into 4 domains where the patient has problems like the pain in the physical realm, pain in the psychological, the social. So I'll just go one by one. So in the physical realm, as you mentioned, he has a painful bed sore in the hip and the sacral region, and he has a bladder incontinence, possibly has a bowel incontinence. So at an age of 35, where he should have been taking care of his mother, he's the one who is lying on the bed, dependent, helpless, at the beck and call of his elderly mother, who on one side has to earn for the family and on the other side take care of her ailing son. So that is one. The social pain I can understand is in most Indian homes, the person who is bedridden is usually left in a corner in the most unattended room, the least ventilated, the least lighted, and away from the daily life, the flow of fresh air or passing of people, and he may face an isolation from the community. And it's good that he is communicating through the phone, because with the availability of phones now, at least the world outside is accessible to bedridden patients. But me personally, as I mentioned, staying in a remote place where even staying at the top of the hill, we don't get a signal, and patients who are poor, farmers who are illiterate, who cannot access mobile phones, don't have this opportunity to explore the outside world when they are bedridden, and they are just left in the corner, and their family members have to go out in the fields to earn their livelihood. In the psychological aspect, I think for a young man to be dependent for the rest of his life, and to know on one side that death is not near and the life is not going to be easy, is a very easy, is a slippery road towards depression. And the whole scenario of suffering just adds on day by day, and there is very less hope in the future. And when it comes to healthcare, when such a person comes to the outpatient department, for me, frankly, my first response would be to settle off all the patients who have diabetes, hypertension, patients who have a cough, patients who have a fever, somebody who might have an answer to their illness, and kind of sideline this person towards the end, because I am personally insecure about whether I'll be able to provide a satisfactory answer to this person, or maybe give a least of the time completely focused on what I want, I think is best for the patient, and not actually asking what is the main concern or the felt need of the patient at that time. So I think in all aspects, all of these, the neglect from the family, the society, the healthcare, the community, all of this together adds to the problems of the patient. And it's not just one sphere, it is a complete, like it's a comprehensive problems in all aspects of his life. And along with that, yes, of course, financial issues where livelihood is a problem, and they live in a rented house, and there is a debt which is increasing every day is another stress to all his problems. Yeah, thank you.
Thank you, Dr. Arnab, for summarizing it really, really well. And I mean, talking about all the possibilities of suffering that he might be undergoing and the limitations in a setting where you are. May I know where do you work?
So I am in Prem Jyoti Hospital, which is one of the hospitals under Emmanuel Hospital Association in Sahibganj district in Jharkhand.
Okay.
We are at the borders of Jharkhand, Bihar, and West Bengal, and we are in that among the tribal areas of Maltos and Santals.
Okay. Thank you, Dr. Arnab. Dr. Ruby, you had raised your hand. Do you have anything to share?
Nothing.
Thank you. So I can see the responses, and I'm so glad that you've discussed all the possible aspects, not just focusing on the pain on the physiotherapy or the quadriparesis part, starting from loss of hope, the anger, questioning yourself like why this happened. And some people have mentioned how it is difficult when he is unable to do his spiritual or the religious activity, where he cannot go to church, which makes him more in distress, and being dependent on the mother, a 65-year-old mother, for his livelihood. And yeah, Dr. Jason has to, I think it's, yeah, so I heard someone, I read someone doing that if the finances were there, it would have been much better. Yeah, Dr. Manjari, yes. The access becomes more available if money is not a problem. Yeah, to some extent, yes. But I think in our country, even with a lot of money, people die in suffering in one form or the other. Either it will be in the community or it will be in a hospital. So yeah, suffering can be a part even if the finances are much better. But yeah, as you said, some of the services are available if we can afford. So I can see a lot of responses other than pain, other than the physical aspect of pain, but the other whatever total pain concept Dr. Divakaran was the total suffering concept that we have been discussing. Yeah. Dr. Jason, yeah, similar to a story of a paralysis patient healed by Jesus in Mark chapter 2, it is the friends and their faith. So also with palliative care. Thank you for sharing that. Dependency on the caregiver, loss of quality of life of patient and the person he loves the most. Thank you so much for the responses. And as a medical or healthcare professional, what all can be done for this patient? Now you have identified all the problems, all the possible problems that he might be undergoing. So how do you think we can help this patient and his mother? What all can be done as a when you come to the palliative care aspect of it? What all can be done as a team or as a healthcare worker? Yes, Dr. Benny, please go ahead.
We actually have a similar patient to this who follows up regularly at our hospital in Assam. He's also around the late 30s and he had traumatic quadriparesis. I think that patient, the main thing that makes a difference is the support of his family. Essentially, he lives in a joint family. So not just his wife and children, but there are multiple caregivers in that family. Most of the women stay at home, they don't work. So he has somebody there constantly with him. So we haven't faced issues like pressure sores with him. One thing is that they were able to procure a electronic alpha mattress from the government. So they have him on that. They use that regularly. They change his position regularly, which we've recommended, and they perform intermittent catheterization on him so that he doesn't have risk of permanent indwelling catheter also causing infection. One thing I noticed recently, even social aspects wise, we had a Mela kind of fair type of thing in our little town. And I noticed that his son and some of his nephews, I guess, young men, they have fashioned some kind of cart thing where they place the patient in the cart. It's not even like a wheelchair. It's actually like a bed with wheels. And it's made out of wood. I'm sure they made it at home. And they actually brought the patient from home on that to the Mela, and everybody in the village was greeting the patient, and they recognize him. They know him from before, but they haven't seen him for a long time. It was just a really beautiful thing to see that this family, along with the support of our center, obviously, but again, we don't have a home team or anything like that. Whenever they come to hospital, we offer them advice, we give pain management and so on, but it's just really nice to see them taking initiative by themselves to do things like this to keep up the social and the emotional health of the patient as well.
Thank you, Dr. Benny, for sharing that. And I could feel the enthusiasm when you are sharing the happiness that you have seen in the patient and when you could make that social interaction possible. I really appreciate that. And that gives meaning to a large extent, that all these questions like, why am I alive? No one wants me. So you've addressed that part. Thank you so much for sharing that experience, Dr. Benny. Yes, Dr. Arnav, please go ahead.
Yeah, I think one of the important thing that we should not ignore is to find different opportunities in how such patients who need palliative care can continue to contribute for the society. So if we can get that point, because suddenly a person who is contributing to the society comes on the receiving end, and that becomes a very debilitating thought for him, because he feels very helpless and clueless. But if we find one or two aspects where this man or a lady or whoever needs palliative care, apart from that, is contributing something to the world, gives more meaning to their life. Thank you.
Very, very valid point. I think finding meaning is something that we need to work on. That helps people to go on even when they are going through a lot of suffering. Thank you so much, Dr. Arnav. Dr. Smita, please.
Yeah, I also wanted to say that if you compare the scenarios that Arnav spoke about and the lady from a doctor from Assam spoke about, it's the family's understanding of the patient's problem and the change in the thought process, which contributes a lot towards how the patient is or the patient is taken care of. If they understand what are the things needed, it is a strain on them, but the mindset changes when there's an understanding and love, of course, but understanding of what the patient's problem, what exactly the person wants, and working towards it. So the education of the family, I think, is extremely important for a better care for such a patient.
Thank you, Dr. Smita. And I think someone else have mentioned about taking care or counseling the family or the mother. That's also very, very important, because we often don't or overlook what the caregivers go through, because as Dr. Arnav was mentioning, like the patient becomes just patient lying down on the bed, and the caregiver has to take care of everything, and she or he may not have the space to talk about it, what she is going through. So it's very important to focus on the caregiver and to talk to them what they are going through. How can we help them to relieve their suffering? Because it's not just the patient or this 39-year-old man going through the suffering, it's also his mother going through a lot more than that. So it's very important to involve the family. Yeah, thank you for bringing up that point. Yes, Dr. Anish.
Yes, so regarding this case, I have a very similar case to tell that as one of my relatives. He was affected by polio and was bedridden from a very young age. And he was taken care by his mother. his mother. So what he used to do, whenever we visit him, we motivate him, and we also used to get him raw materials to make paper covers. So he used to make paper covers at his bed, and his family used to sell that in the shop. The only income for the family was a provision store, which his father was running, and these covers were used in that provision store. So in that way, he was psychologically feeling comfortable that he is being supportive for the family, and that is a major thing. That just like the other doctor said, we should make them realize that they are not a burden and they are useful in a way. And we should also give them motivation, whoever can, and basic care to increase the quality of life is also important. So these are the things I think. Additionally, I would like to add that training the patient to do some productive things like making candles and paper bags, umbrellas, paper pens, etc. will be helpful for their psychological motivation.
Thank you, Dr. Anish. I think we are about to reach the time. I think I'll just want to, I'd like to hear from Dr. Divakaran. Sir, you have heard from everyone, like how people identified the suffering and how they plan to manage. Just a few words from
that was a wonderful discussion, and everybody has picked up the essential features of palliative care, and I think they have got the feel of palliative care. Now, an additional, no, it's not an additional, it's an extension of what they said. One is that we have to give aggressive physiotherapy so that whatever improvement he can have with his hand, at least, he can, this paper bag or something like that, they can make and productive life. They can enter into productive life. That will tremendously improve his self-esteem. So that's in a very low state because he is being. And another thing we can do is that we can give some respite care for this patient so that the mother can have some relief that we usually do for such patients. We take care of the patient for 1 or 2 weeks so that by the time the mother can recharge herself. The caregiver burden, the burnout issues can be avoided. That's all I think. It was a very good discussion.
Thank you, sir. Maybe one last comment from Dr. Ashira. Can you unmute yourself and talk, Dr. Ashira?
Yeah, Dr. Sancha, somehow I'm not able to remove the name. Ma'am, here I'm working for IBAS. So we have this stroke dance program where we take care of the stroke patients' relatives. And people with quadriplegia relatives, we give them a venting out session. Also, this is a quadriplegic patient you're discussing, but if we have people with hemiparesis or with just slurring, we actually have this program where they interact, and we have a specialist, we have a neurophysiotherapist. So he conducts a lot of programs and we work with them on those bases. We're planning to start the neuro palliative care here. It is just been approved by the ethics committee. So that one, I have done my course a long time back in 2008. So just to refresh myself after so many years, though in between I have been associated with palliative care. Unfortunately, I had a relative who expired to palliative care. And in Bangalore, there is this UB Care platform. Like you have Urban Clap in Delhi for other things. You have a UB Care product where it's a platform that you can go and you can hire things for palliative care. So basically, you can get the mattresses, you can get the down sheets and things like that. And there are nurse sisters who stitch diapers and help out. So, ma'am, in Delhi, all this is there, but people don't have real access to it. And us being a government setup, we are doing all this in a very minute focus. Our footfall is a lot. We're doing 3,000 patients a day. So we're not getting time to leave the ICU and focus on that. Even our plain clinic suffers sometimes because we're overwhelmed. But we are working, and the hospital also is expanding. So we're going from 300 to 500 beds. So once we have better infrastructure, we will be able to focus on that. So I just wanted to say this one part of neurophysiotherapy. We have very good occupational therapy. We also have been given by the government a yoga specialist. So we also are working on people's mind, which is very important because we all live in our minds. So that's something which is going on. And thank you, ma'am.
Thank you. Can you just tell me your name, because your name is shown as something?
Yeah, it's Kanavas.
Sorry?
I will be typing it in. I will be typing
Thank you so much. And I'm really interested to have a conversation with you, like the work that you do in neuro rehab and the other activities. Like we definitely have a chat about it. Like this is a really interesting area for
yeah,
us
ma'am. I
also.
was very interested that somebody to help out with starting the palliative care.
Yeah, I think we lost her. I think, yeah, we overshot 5 minutes. Sorry for that. Thank you so much, everyone, for the wonderful interaction and the responses. And we really look forward to these kind of interactions from your side, so that like this, we can have, like, I learned a few things today. So like that, we learn from each other in the coming 19 sessions. Thank you so much, Dr. Divakaran, for being with us for the first session and for sharing your knowledge and expertise in this area. Thank you so much. And thank you so much, all the participants, for being with us. See you on the next session, Shripriya.
Thank you, Dr. Divakaran, for joining us. We do know that yours would have been a really busy day, and you could find out quality time for our participants and interact very actively with them. Thank you so much for your valuable time. And thank you all the participants for making this interaction, making this session an interactive one, really interactive one, as we could see that there were exchange of information. And we have kickstarted a journey which we believe will be continuous and successful. So with that, we'll be having many more sessions coming up, many more interesting topics and many more eminent faculties. So please look forward for the same. So with that positive note, and reminding you to submit the feedback. This is Shripriya along with Dr. Divakaran and Dr. Sridevi signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care, be happy, bye-bye.
Bye. Thank you.